Numbers are thrown out all the time. Are they proof of some truth or just fluff that bluffs us? These statistics, they need some serious looking into. And that's what I'll do. I'm Brendan Fernandez. We find out the story behind the statistics. Because some numbers are just worth figuring out.
You know the old saying, health is wealth. In some parts of the world, that's exactly what people are afraid of. But falling sick is a luxury they can't afford. And I'm not just talking about the third world. In the United States, the #1 cause of personal bankruptcy is medical bills. In the first ever survey of the world's healthcare systems, the World Health Organization, or WHO, ranked the US only 37th out of 191 countries surveyed.
Mr. Brendan Fernandez.
Singapore, on the other hand, ranked as the best in Asia and the 6th best in the world. So what do we spend on this state-of-the-art healthcare system?
Surprisingly, not much. Here's how much we spent. Here we have healthcare spending as a percentage of GDP, and here the years since 1995. As you can see, over the years since the 1990s, it hovers around 3 to 4% of our GDP. If we divide that, it works out to about 2,000 Singapore dollars, or around 1,600 US dollars per person. Let's compare that to other countries. Here's a bird's eye view of the world's spending on healthcare as a percentage of GDP. The darker the shading, the higher the spending as a percentage of GDP. Let's take the peer pressure approach, one of the approaches recommended by the World Health Organization, or WHO, to answer the question, how much should a country spend on healthcare? That involves comparing Singapore with other countries with similar characteristics like income levels, culture, or epidemiological profile, which is the study of health and disease conditions in populations. So let's look at the usual suspects from the developed world: the US, the UK, Australia, Japan, Sweden, and Germany. Let's take a look at our earlier chart, Singapore's spending on healthcare as a percentage of GDP. How do we fare against other countries? Singapore spends well below them, less than half of most, and less than a quarter of the United States average healthcare expenditure. Even in terms of the average dollar amount per person, Singapore's 1,600 US dollars pales in comparison. Now, there is no recommended standard for how much a country should spend on healthcare as a percentage of its GDP. But when we benchmark ourselves, we often look at the Organization for Economic Cooperation and Development, the OECD. And this is the OECD average health expenditure as a percentage of GDP, 9.5%. That's more than double Singapore's budget.
How do we keep our healthcare spending so low and yet not compromise on quality? For answers, I speak to Dr. Carol Tan, a specialist at Raffles Internal Medicine Centre.
Dr. Tan, how do we keep spending on healthcare low compared to, let's say, the OECD countries?
First, the other countries in the OECD tend to have aging populations. They aged a lot faster than we did. The second thing is that we have a lot more of what we call lifestyle differences. We tend to exercise more. We don't have a large number of obese patients or obese populations, so that is also different. One of the key differences in those countries is also how the entire system is structured. There's a very interesting paper from United Kingdom, and everybody quotes the NHS system, where they talk about the role of government as a nanny or a steward.
A nanny or a steward?
Correct.
Okay.
In certain countries where the state plays a nanny role, the state decides, and then people just receive the care.
Singapore has gone the route of the steward. Our healthcare system champions individual responsibility with some state-sponsored safety nets to ensure everyone has access to basic health services. The government pays up to 80% of the total bill in acute public hospital B2 and C-class wards. The remaining 20% is usually covered by MediSave, a mandatory medical savings account, and MediShield, a low-cost medical insurance scheme.
So why the system of co-payments? It's to prevent overconsumption and abuse. But it does mean that private expenditure on healthcare, whether by us or our employers, is higher compared to other countries.
In countries such as Germany or in Sweden, the government imposes a cap on what the individual pays. And because of this cap, this helps to prevent concerns around things like bankruptcy due to high medical fees. But in Singapore, we do not have such a system. And in theory, the co-payment, despite being 20%, can run into the many thousands of dollars. In this year's budget, the health minister has already articulated that the government wants to spend more.
Why the change in tune? Because, over the years, there hasn't just been a change in the way we live, there has also been a change in the way we die. In the 1950s, the biggest killers were tuberculosis, pneumonia, and diarrheal diseases. These are acute diseases. This means there is a sudden onset of symptoms, and death usually comes soon after. The principal causes of death today are cancer, heart disease, and stroke. These three accounted for about 61% of all deaths. Apart from a few types of cancer, these are chronic diseases. This means that they are long drawn out and can result in varying levels of disability.
The reality is it is a lot cheaper when you have an acute illness. Even if it's expensive, $2,000, if you only pay it once, you can afford it. But if you're paying $2,000 every month or every 6 months for the rest of your life, it is very difficult. For chronic disease, it's a whole continuum of care that you need to have.
It was only as recently as 2006 that you could use your MediSave to pay for outpatient treatment. But there are a few catches. Only at participating clinics, for 10 specified chronic diseases, and a maximum of 400 Singapore dollars per MediSave account per year. Regardless of the number of chronic diseases you may have.
If you have 10 children, then it is easier. It becomes affordable because you can 10 children times 400. But I think things have changed now. We don't have that many children, and so therefore 400 for only one person may not be enough because the drugs are expensive, the tests are expensive. And so when we review as to whether something is adequate, it is a good start, but perhaps it needs to be regularly reviewed as to whether it is enough.
So it seems, besides this change in the disease patterns in Singapore, the price of life is also on the rise. Medical inflation is about 3% on average every year.
This is partly due to general inflation and partly due to advances in medical technologies. So we have new drugs, we have new devices.
Part of the government spending goes towards this, the Standard Drug List, or SDL, drugs subsidized by the government.
There are more than 500 drugs on the list. The cost of the drugs on the SDL is subsidized for Singaporeans who stay in B2 and C-class wards in public hospitals. The subsidy can cover as much as 75% of the cost. But how does MOH decide which drugs get into the list? A drug advisory committee made of senior specialists from hospitals and MOH reviews the SDL every year. It relies on professional cost-effectiveness analyses done locally and abroad.
Here in Singapore, it is not in the public domain as to how the specific calculations or what is the underlying methodology used. But at this stage, it's a fairly opaque process in that beyond general principles, members of the public and even the experts who are outside of the health ministry will not know what are the detailed breakdown as to how such policy reimbursement decisions are made.
In other words, we don't know the actual math. Is that because there isn't an objective formula to calculate the cost-effectiveness of a drug? Well, no. There is an internationally recognized measure of the effectiveness of a medical drug or treatment commonly used in other parts of the world, like the UK or Australia.
It's called the cost per quality adjusted life year, or cost per QALY for short. It takes into account both the quantity and quality of life added by a particular medical intervention. The quantity part is easy. Let's say a particular drug adds 5 years to your lifespan. In this case, it scores 5. The quality of life is represented by a value between 0 and 1. 0 meaning death and 1 meaning perfect health. So let's say that the quality of life of this same drug is 0.4, because you may experience some side effects. So you take the quantity of life multiplied by the quality and you get the QALY, which in this case is 2. Next, we generate what we call a cost-utility ratio. Let's call this drug drug A. Drug A is the new treatment for medical condition X. The current treatment for medical condition X is drug B, which has 1.5 QALY. So if you took drug A instead of drug B, the QALY added would be 2 minus 1.5, 0.5. Is this half a year worth the cost? Let's say drug A costs $10,000 and drug B costs $5,000. So the cost-utility ratio of drug A would be the difference in the cost of the two drugs divided by the difference in their cost per QALY. So drug A's cost per QALY would be 10,000 US dollars.
Now, some countries will look at the cost per QALY of a drug or treatment to decide whether it is cost-effective or not. In the UK, for example, anything above 45,000 US dollars per QALY is not considered cost-effective. So drug A, in this case, would be considered cost-effective.
This, in a sense, provides a universal currency to compare services, to compare drugs across different specialties.
Now we know what the minimum money can buy is. What is the best money can buy?
This is the Mount Elizabeth Novena Hospital, one of the newest private hospitals in Singapore.
All rooms here are single rooms, and one will cost you between $465 US and $10,400 US a night. Singapore has 10 hospitals and specialty centers in the private sector, and Mount Elizabeth Novena is one of the newest. The private healthcare sector houses 15% of the hospital beds in Singapore and caters to about 20% of our population. This means that its bed occupancy rate is on the low end of the spectrum at 40 to 60%.
Compared to private hospitals like this one, the public sector houses 85% of the hospital beds in Singapore, which makes sense because they take care of 80% of the population. Bed occupancy rate is anywhere from 80 to 95%.
In 2011, we had a total of 11,394 beds in Singapore.
Let's look at the density of hospital beds. That means the number of beds available per 1,000 people. In the 1960s, we're looking at 4.39 beds for every 1,000 people. Since then, this number has been on a downward trend, which means less beds for the same number of people. This is where we were at last count in 2011, 2.2 beds per 1,000 people.
This 2.2 beds includes both private and public hospitals. If we take out the private hospitals from the equation, it would be 1.72 beds per 1,000 people.
Compare this to the density of hospital beds in some other OECD countries. Here's the density of beds in some high-income economies. On average, OECD countries have 3.4 beds per 1,000 people. Singapore is below that average. But according to the Healthcare 2020 Master Plan, the Ministry of Health is already planning to tackle any dip in hospital bed availability as our population grows. This is the map of Singapore. By December 2013, 79 beds will be added to the National University Hospital, or NUH, in the west. 50 beds each will be added to community hospitals, Ang Mo Kio Tai Hwa Kwan and St. Luke's. 4 more community hospitals and 2 general hospitals are due to be completed between 2014 and 2020. This will add 4,100 beds to our public sector, which will bring our bed density up from 2.2 to 2.27 per 1,000 people. So the question is, will that be enough?
I think it comes down to also the definition of what is a bed. Is it a bed in a hospital setting, or a bed in a community hospital setting, or say in a nursing home setting? We had a fairly young population, so our bed density was low. Whether it should go up is another issue again. The reality is it is much better to be managed in a community setting and not to be admitted to hospitals unless you really do need it. It is also cheaper to be in a community. A hospital bed is very, very expensive.
So moving towards community care could alleviate the need for more hospital beds. But there is another thing the public sector could use more of: doctors. There were a total of 9,646 doctors in 2011. This put our doctor-patient ratio at 1 to 540.
How do we compare to the first world in doctor-patient ratio? Let's take a look at the big 5, the US, the UK, France, Germany, and Australia.
The average doctor-patient ratio of these 5 countries is 1 to 366. So on average, our doctor has to deal with 174 more patients than his or her counterpart in these countries. But then again, it depends on whether the doctor in question works for the private or the public sector. If we're talking about specialists, 60% or 6 out of 10 work in the public sector. The other 4 out of 10 work in the private sector.
It seems that more specialists work in the public sector, but the distribution of work between private and public sectors is not the same.
In Singapore, 8 out of 10 people depend on the public sector for their more expensive hospitalization needs. So the 6 out of 10 doctors in the public sector will deal with these 8 out of 10 patients, while the 4 out of 10 in the private sector would only have to deal with these 2 out of 10 patients. But the good news is that the proportion of specialists in the public sector has been steadily growing from about 56% in 2001 to 62% in 2011.
The public sector has been very aggressive in its recruitment efforts, both locally as well as overseas. Secondly, the public sector has been putting in a lot of effort into retention. So salaries have gone up.
In preparation for a growing and an aging population, our healthcare financing system will be undergoing a revamp. For one thing, the yearly budget will double from the current 4 billion to 8 billion Singapore dollars by 2016.
Now, will spending a few or a lot of extra dollars help solve our healthcare problems? We know that the OECD countries spend a lot more than we do on healthcare, almost double. But does it buy them a more efficient healthcare system? Here we have total healthcare expenditure per person per country, and here's the infant mortality rate. It is one of the health indicators used by the World Health Organization, or WHO, to assess a country's healthcare system. The lower this number, the better. And how do OECD countries do in infant mortality in relation to how much they spend? Countries like the UK, France and Germany have a rather high infant mortality despite spending more. The US does very poorly. Here's Singapore. We get more bang for our buck. We spend about $2,100 and our infant mortality rate is low at around 2. Let's look at a different health indicator, healthy life expectancy, the average number of years a person can expect to live in full health. The higher the number, the better. Most of the OECD countries do pretty well and are judged as having efficient healthcare systems. Except the US. They spend about $7,000 and have a healthy life expectancy of about 70 years, which is about the same healthy life expectancy as Singapore, except that we spend $2,100. We may not fare as well as our European counterparts, but we're considered efficient. So throwing money at the problem isn't the solution.
Instead, perhaps we should be looking at more flexibility, like perhaps portability of government subsidies, so that more of the population could use private healthcare services, so that we could alleviate the waiting time, the burden on specialists, and the bed crunch in the public sector.
Well, it's clear that without subsidies, the private sector is inaccessible to the average Singaporean. Right? And if we want to optimize Singapore healthcare at the system level, we really do need to think about portable subsidies. What happens in other countries such as Australia, it works almost on a voucher system where the government says that for a certain service, for a particular consultation, the government will reimburse the provider with X dollars. And the government is agnostic as to whether it's in the public sector or in the private sector.
So while we have a healthcare system that is reasonably up to mark, times are changing. Singapore is facing an aging population, changing disease patterns, and a new, smaller family structure, which means that the way that we finance our healthcare needs, if not a rehaul, at least a facelift.